Hello, welcome to our Healthcare for All Minnesota Physicians for a National Health Program and Minnesota Nurses Association Education and Outreach Committee event for this evening. It's Thursday, September 16th, 2021 at 6:30 p.m. We are glad that you chose to spend some time with us this evening. Our topic for this evening is why are healthcare costs in the U.S. and Minnesota so high, and this is the first of 3 sessions on this topic, and we're going to start this evening with an overview of how we got here. Our agenda for this evening is a welcome and instructions for attendees, the purpose of the program, which I'll talk a little bit about. I will then introduce our speaker for this evening, Kip Sullivan. We'll have a question and answer period, and then some announcements and a wrap up. Okay, with that, I want to give you all a little bit of background on where this presentation originated. Our Healthcare for All Minnesota Legislative Relations Committee, which is formed to monitor and analyze current and proposed legislation related to cost, quality, and access to healthcare nationally and in Minnesota, developed this program because we know we need a lot of education on the issue of healthcare payment reform to provide information and training for the public, for our activists and advocates for change, and also for members of the legislature. You can't just assume that because somebody's in elective office that they have an expertise on every subject they may ever be asked to vote on. So we consider ourselves responsible for being honest brokers on our area of interest, which is cost, quality, and access to healthcare. The committee hopes to reinforce that a clear understanding of factors contributing to the current system is key to avoid using flawed assumptions and failed policies to craft future solutions to the problems of cost, quality, and access. This is the first in a series of 3 sessions, like I said, to educate our own advocates and activists and also our legislators. And again, thank you for being here. Please invite others to our upcoming sessions. I want to just expand a little bit on the biographical information that you saw when you signed up for this event this evening. We did include some background on Kip Sullivan, a longtime activist in this area, but I want to just add that Kip has been a relentless advocate for a data-driven and policy-oriented approach to healthcare payment reform for decades. And he has contributed immeasurably to the rigor with which proposals for change are viewed, including the One Payer States Organization Policy Committee and our own Healthcare for All Minnesota Legislative Committee, and with members of the legislature. And with that, I'm going to turn this program over to Kip. Welcome, Kip.
In the October and November webinars, the most fundamental answer is that Congress and the Minnesota legislature endorsed the wrong diagnosis of the problem. They were fooled into thinking that our healthcare costs are high because Americans overuse medical care. In other words, we get large quantities of unnecessary services. That was the wrong diagnosis. The correct diagnosis was and is that the price of medical goods and services sold in America is excessive. It wasn't the quantity or volume of medical care. It was and is the high price of drugs, insurance, some physician fees, hospital fees, etc. You also know this, that if we're concerned about total spending in any sector of the economy, we have to be concerned about 2 numbers. The quantity of whatever we're talking about, bananas or healthcare, and the price. The price of bananas times the quantity of bananas gives you total spending. U.S. and Minnesota legislators concluded without evidence that excessive quantity is the problem. To make matters worse, that wrong diagnosis, overuse, fooled legislators into endorsing a solution, managed care, a term I'll define in a minute, that not only didn't work, it aggravated the cost problem and worsened disparities. How did this happen? Over the years, I've discovered that the most effective and entertaining way to answer that question is to tell you the history of America's debate about how to get our healthcare costs down. That history is about 50 years old now, and I'm going to get through it in the next 40 minutes. But to do so, I'm only going to cover the major issues. I will not be talking about a lot of the secondary issues tonight. We will look more deeply at them in October and November, and we'll take a longer look at the research. I'm going to divide this history into three parts, three eras, 1929 to 1970, which gets us 1970 to 2000, and 2000 to the present. The 1929 to 1970 era gets us from the birth of the insurance industry through the enactment of Medicare and Medicaid, and the beginning of the modern healthcare reform debate in 1970, in particular the HMO managed care revolution. The 1970 to 2000 period will see the rise and fall of HMOs, and we will end in the late 90s with the HMO backlash. And the third era, 2000 to the present, I won't have much time to talk about tonight. I'll get into it in more detail in October. But the important developments there were new iterations of managed care, post-HMO backlash. These new iterations, particularly something called the Accountable Care Organization, were endorsed by the Affordable Care Act in 2010. And we'll talk about the spread of high deductible policies, primarily because America's healthcare cost containment policies were not working. During that 1970-2000 period, we will see the arrival of the three camps or schools of thought that have participated in the debate about why U.S. costs are so high and what to do about it. And in the order in which they appeared, they are the single payer camp, the managed care camp, and the high deductible skin in the game camp. Pretty much anybody who has participated for any length of time in this debate falls into one of those three camps. When I'm done with this history, you'll understand the position of each of these camps. And when I say position, I mean their diagnosis, that is their explanation of the problem, and their solution. Not surprisingly, solutions tend to follow your diagnosis. I'm going to devote most of my time tonight to the managed care camp because they have dominated the debate in this country really for the last 50 years. In fact, it's no exaggeration to say they've controlled it, and they have kept single payer and to some extent the high deductible camp on the sidelines. And if you'll bring up the first three slides, I want to start with just a couple of slides on just demonstrating the problem that we're discussing tonight, which is the high cost of healthcare. In this slide, you see that, can you go back to the first slide, Ann? This is a slide I think you've seen in multiple ways often, those of you who've been involved in the fight for universal coverage. What you see here is that U.S. per capita spending is much higher, roughly double that of the other wealthy industrialized nations you see here. If the U.S. were the only country on this list that covered everyone, and the other 9 were countries that left 10 to 15% of their people uninsured, we wouldn't need this webinar because there'd be nothing basically to explain. You could say, yeah, we're more expensive because we cover everyone. That is just not the case. It's the other way around. Next slide, please. Then to sharpen the anomaly, the U.S. Has many more of its citizens saying, I could not afford healthcare because of cost. Here you see a poll indicating that in the U.S., 33% of Americans said in 2016 they skipped care because of cost. Those numbers are far lower in other countries. Next slide, please. This next slide I'm going to talk more about in the November webinar. Here you see a graph showing Minnesota's per capita costs as a percent of U.S. per capita costs. And you see from 1970, this It's a rather small version of the graph that we're looking at, but the far left number is 1970. And just where that red line begins to turn up, that is the year 1992. And I just want you to tuck that year away, because we'll have occasion to talk about that year again. The events that happened then have something to do with this steep slope of this line. You see that by the end of the 90s, Minnesota's per capita costs were 10% above the national average. It stayed that way until 2014, which is the latest data we have at the state-by-state level. Now, I want to turn to the first era, 1929 to 1970. There was no health insurance in this country, health insurance industry in this country prior to 1929. You could buy life insurance, sickness insurance, burial insurance, but you couldn't buy health insurance. What changed that was the Great Depression. Doctors and hospitals wound up having patients who could not pay their bills, and they basically invented health insurance as a way to help their patients pay their bills. The first successful health insurance company was started by the hospital affiliated with Baylor University in Texas, in Dallas. The hospital offered 1,400 Dallas school teachers free hospital care 21 days a year for the immense sum of $6 a year. And it worked. The hospital didn't go bankrupt. The teachers were satisfied. The first teacher to use her this newfangled thing called health insurance was Alma Dickinson. She broke an ankle around Christmas and spent the holidays in the hospital. In Minnesota, 7 Twin Cities hospitals decided they would try the same thing. In 1933, they offered the same deal to the employees of the South St. Paul Meatpacking Company. They charged them $9 a year. And they chose as their symbol a blue cross hovering in the sky. And for some reason, as hospitals across the country began to mimic what the Twin Cities hospitals and Baylor were doing, they also adopted that blue cross symbol. When doctors saw the hospitals making a go of it with their blue crosses, they started Blue Shield. Doctors in California were the first to start a physician-only, physician-run insurance plan, and they adopted the logo of a Blue Shield. When for-profit insurance companies like MetLife and Prudential saw that the nonprofit Blues were making a go of it, they jumped in. And by the late 50s, 2/3 of Americans had health insurance. So you could say that the health insurance rate had fallen from 100% in 1929 to approximately 35% by the late 50s. Now, until 1979, we had no regular measurement of the uninsured rate. The U.S. Census Bureau began asking questions about health insurance in 1979. So the percentages I give you for years prior to that are from a variety of different studies by different researchers. Now I want to stop and comment about 2 features of this first generation of health insurance companies. The first is that they paid doctors and hospitals by a method called fee for service. It means what it sounds like it means. Doctors are paid a fee not before a service, but after they've rendered it, and on a per service basis. The second feature to note is that this first generation of insurance companies did not own or contract with doctors and hospitals, often called providers collectively. If the claim was clean and the doctor or hospital was licensed, the insurance companies paid the bill. Now, who were the 35% of us who were uninsured in the late 50s? They were disproportionately the poor, the unemployed, and the elderly. And Congress addressed that problem, not completely, but substantially, by enacting Medicare and Medicaid in 1965. You all know what Medicare is, mainly for the elderly. In 1972, people of all ages with end-stage kidney disease and disability so severe they can't work were added. Medicaid, we must stress, is for some of the poor. It's administered by the states. and they the states split the costs with the federal government. The most important thing to say about Medicaid and Medicare when they were first implemented is that there was no middleman. Money was not funneled from Medicare or Medicaid through an insurance company first, so that they could scrape 15 to 20% off the top and pay the rest to doctors and hospitals with strings attached. Now, the enactment of Medicare and Medicaid had two substantial effects, one long-term and one short-term. The long-term effect was to drive the uninsured rate down remarkably to 1/3 of its former level. You see here on this chart, this slide, that a study done of the uninsured rate in 1963 said that 33% of us were uninsured. But studies done by the late 70s indicated that the rate had fallen to 11%. But it didn't get any lower. And then it began to inch up, and you see that it peaked at 16% in 2010, and then it fell gradually to 9% by 2015. The Census Bureau just reported data yesterday for the year 2020, and they're saying that the uninsured rate for that year was 9% as well. A report that I read yesterday said that the uninsured rate for 2018 was actually 8%. And I haven't had a chance to understand why that got changed. Maybe the Census Bureau just reevaluated their data. Anyway, take this last line with an asterisk, but it looks like we are currently at America's record low rate of a 9% uninsured rate. That was the most important long-term effect of the enactment of Medicare and Medicaid. A short-term but significant and important effect was that the enactment of Medicare and Medicaid kicked off a brief 5 or 6 year bout of inflation in healthcare costs. And that shouldn't be surprising. If you give people money to get into a market that they were previously locked out of because they didn't have the bucks to participate, the supply side doesn't have a chance to expand, and if there are no price controls, they are free to raise their prices, and that's what happened. Doctors and hospitals raised prices rapidly in the late 60s. Compared to what we spend today on healthcare costs back in the late 60s were very small. Back then in 69, 1970, America was spending 7% of our entire national income on healthcare costs. That number today is 18%. Nevertheless, that brief burst of inflation in the late 60s greatly concerned Congress and employers. Richard Nixon stated in July 1969, Nixon was the president then, "We face a massive crisis." And so the stage was set for the second era that I want to tell you about, which was the era really in which the modern healthcare reform debate began. Now, if you had to pick a single month to say this is when the modern healthcare reform debate began, I would say January 1970. That month, Fortune magazine and Business Week carried cover stories on the healthcare crisis. Here's what Fortune said: "America's medical system stands on the brink of chaos." And that same month, January 1970, Senator Ted Kennedy and Representative Martha Griffiths from Michigan introduced what today we would call a single payer bill. Now, let me just stop and define that term. I know many of you know what that is, but this is a presentation we're hoping to develop for people who are not that familiar with health policy, so bear with me. The label single payer did not enter the lexicon until the latter half of 1989. And when it did, it was introduced to label a proposal by a new group called Physicians for a National Health Program, PNHP. PNHP had just published an article in the New England Journal of Medicine in January 1989, laying out a plan for universal coverage coupled with cost containment based on the mechanisms used by Canada. That system today, we say, has 4 elements, and you see them here on this slide. The most essential element, of course, is one payer. That's how it got its name. The one payer replaces 1,000 insurance companies today. Back in the 80s, it was probably more like 3,000 insurance companies, but thanks to merger mania, we're down to about 1,000. The one payer replaces 1,000 insurance companies and many thousands of self-insured employers. A self-insured employer is typically a big employer like Walmart or 3M, who sets aside enough money to pay the bills of their medical bills of their employees as they come due. So one payer replaces 1,000 insurance companies and many self-insured employers. The second element is the one payer negotiates budgets with institutional providers, defined in most proposals as hospitals and nursing homes, although you'll see a longer list in some proposals. The third element of a single payer is a uniform fee schedule for doctors. And the fourth is the single payer. The one payer negotiates limits on drug prices with drug manufacturers. Single payer systems save money primarily by reducing price, not quantity. And it reduces prices mainly by reducing administrative costs, which drive prices up. They reduce prices secondarily by negotiating payments to providers and to drug companies. Now, this is an example where I'm going to just talk very briefly about the research. We'll talk more about research in the next two webinars. This is a quote from an article from people affiliated with PNHP, published about 18 months ago in the Annals of Internal Medicine. You see that it basically says that America devotes 34% of our total healthcare bill to administering our complex system. By contrast, Canada devotes only 17% of its total healthcare bill to administration. Now, look at that 34% number. That is roughly, the data here doesn't allow us to be too precise, but that 34% spent on administrative costs is roughly due half and half to the insurer sector and half to the provider sector. When I say insurer sector, I mean those 1,000 insurance companies, all those self-insured employers, Medicare, Medicaid, that's the insurer sector. And then the provider sector, of course, is doctors and hospitals, nursing homes, etc. Let me just give you a quick look at both sectors. Next slide. We know that in the insurer sector, we save a lot of money by going to a single payer because the costs of administering the system drop precipitously. The typical insurance company has an overhead of 20%. And by that, I mean it's administrative costs for marketing, telling doctors how to practice medicine, lobbying, negotiating networks with doctors every year. Whereas traditional Medicare, which is an imperfect form of a single payer, has only a 2% overhead. So to put it another way, if you give an insurance company $1 worth of premiums, they keep 20 cents to run their shop and pay out 80 cents to doctors and hospitals. You give $1 worth of taxes or Part B premiums to Medicare, they keep only 2 cents to run their shop and they pay out 98 cents to doctors and hospitals. Now let me take a quick look at the next slide, which will give you a glimpse of the kind of savings we achieve with a single payer on the provider side. Here you see research published on the cost in Canada and the US that doctors incur dealing with payers. And you see that the Canadian doctors per doctor spend 1/4 as much as American doctors do coping with payers. Now that is a quick description of what a single payer does. That's what Kennedy and Griffiths introduced in January 1970. Now let's go to the very next month, February 1970. That month, a Minnesota physician named Paul Elwood had a meeting with 3 of President Nixon's representatives in the DuPont Plaza Hotel in Washington, D.C. Nixon knew he was going to run for re-election in 1972. He knew he had to have a plan of some sort to deal with healthcare costs. And he did not want Medicare for all, which is what Kennedy and Griffiths were proposing. And Elwood came into that meeting in the DuPont Plaza Hotel with the same message. He said, if the Republicans don't come up with a market-based solution, we're going to get Medicare for all. Elwood said to those 3 Nixon reps that the reason American healthcare costs were rising was due to overuse, excessive quantity. He said that when in fact the problem was rising prices. Elwood was fixated on the quantity number in that price times quantity equation. He claimed that patients are getting many unnecessary services because of the fee-for-service method of paying doctors. Now, there's a kernel of truth to that argument, and it sucked a lot of people in. Yes, if you pay anybody, piano teacher, bread maker, doctor, a fee for every service or good provided, they have an incentive to provide more of it. But Elwood had no evidence that doctors were caving in routinely to the fee-for-service incentive to order services patients didn't need, and there's still none. Again, we'll talk more about that in the October session. But Elwood got it into his head that quantity was the problem and fee-for-service was the cause of this excess quantity. So if that's the diagnosis you get in your head, what's the solution? Well, Elwood's solution. Let's turn the fee-for-service incentive upside down. How do we do that? He said we will pay doctors capitation. Capitation is based on the Latin word caput, per head. It means doctors or clinics or hospital clinic chains are paid a fee per patient per year. And so, for example, if I want Dr. Ann Jones to be my doctor, I say to Medicare or Blue Cross, you set aside $10,000 in Dr. Ann's account for KIP for 2021. And if Kip never gets sick, she keeps the $10,000. And if he gets hit by a truck and it costs her $50,000 to patch him up, she eats those losses. That's how capitation works. And you can see that it does create the opposite incentive, which is to deny services to patients. Elwood claimed that capitation would not only cut unnecessary services and only unnecessary services, he also said that it would induce doctors to care more about preventive services. And that once doctors just really started understanding how important flu shots and prostate exams are, they would begin to do more of it under capitation. He was so convinced that prevention would play a major role under capitation that he called his newfangled insurance company a health maintenance organization. He coined the name. The only thing that's unclear is whether it occurred at that meeting in February 1970 at the DePauw Plaza Hotel or a couple of months later. We will talk more about this in the question and answer session if you're curious. Prevention, most preventive services do not cut costs. And all I'm going to say about it here is throw up here a couple of quotations from some experts. We can talk more about why that's true. Note that what this slide does not say is that prevention is bad for patients. That's not what it says. It just says that Elwood was wrong when he said capitation will increase preventive services and preventive services will reduce costs. Now, to come back to Elwood's definition of an HMO. Now, if you agree to capitate doctors and clinics and hospitals, then you must also agree to limit the patient's choice of doctor. It is neither logical nor fair for me to designate Ann as my doctor for 2021 and she gets the $10,000 in her account. And then when I get hit by the truck, I go somewhere else to have me get patched up and then have them send her the bill. It can't work. It's not fair. It makes no sense. And so if you believe in capitating doctors, then you also have to concede you agree to limiting patient choice. So that was the second major feature of this newfangled thing, this new HMO that Elwood was selling. And just in case those first two tools, capitation and limited choice, didn't do the trick, Elwood was also comfortable with insurance companies micromanaging doctors. And the most well-known form of micromanagement of doctors by the 80s was called utilization review. And it just means that doctors have to play Captain May I with insurance companies on major decisions, whether to hospitalize the patient, how long to keep the new mom in the hospital, whether the patient can be switched from one statin or antidepressant to another. Those three HMO tools came to be called managed care by the mid-'80s. It might more appropriately have been called managed cost, but that's the name that came into use in the mid-'80s, and it has stuck. Now, if you'd been in that February 1970 meeting with Elwood at the Plaza Hotel, what questions would you have had for him? I understand the meeting went on for about 4 hours. I have 6. Here are my 6. Dr. Elwood, where's the evidence Americans get too many medical services? Didn't have it. Where's the evidence that whatever overuse occurs is due to fee for service? Didn't have it. 3, where's the evidence that capitation induces more prevention? Didn't have it. 4, where's the evidence that prevention saves money? Most don't. 5, why won't HMOs harm patients? You're subjecting doctors to financial incentives to deny them care, and you're putting people without medical degrees in charge of second-guessing doctors. Elwood did have an answer to that one. He said, somebody somehow, somewhere, at some unknown expense, is going to prepare report cards on both HMOs and individual doctors and hospitals. He never described it. I do not know what he was imagining. So if you are looking for the best doctor to treat a gunshot wound after you get shot, you're going to run to a library and look up gunshot wounds and check out the grade on several HMOs and several doctors, or who takes the best care of diabetics. It was a silly, substance-free proposal, but that's what he said. But it became part of American and Minnesota health policy big time in the 90s. And my 6th question for Elwood would have been, Dr. Elwood, we've been here for 4 hours. You haven't said a word about high prices. How come? And I'm sure he just looked at me with a blank look on his face, because he never, at that meeting and in subsequent writings that I've read, price was just not an issue for him. It always was overuse in quantity and a fee-for-service inducement to overuse. Now, despite the absence of evidence for Elwood's diagnosis, overuse due to fee-for-service, and his solution, HMOs plus report cards, Nixon and eventually the Democrats, including Ted Kennedy, bought his proposal. Democrats and Republicans worked together to insert HMOs into Medicare in 1972. That was the beginning of this awful program we call today Medicare Advantage, which are vastly overpaid now to ensure 40% of all Medicare beneficiaries. Democrats and Republicans worked together to pass the HMO Act of 1973, which subsidized the formation of HMOs across the country. Minnesota also enacted a very similar HMO law in 1973. So very quickly, Elwood's false diagnosis and his evidence-free seat-of-the-pants solution, HMOs plus report cards, had a powerful influence on policymakers. It is, and it only got more powerful as the years went by. It's impossible to exaggerate the power of the groupthink that Elwood helped start. The power of that groupthink over the minds of intellectuals in academia and media and in politics for the last 50 years. And the result has been cost containment policies that have been focused on quantity and almost none on price. And to drive that point home, let me just read to you a sentence from an op-ed published in the Wall Street Journal in 2015. It was written by Drew Altman, who is the president of the Kaiser Family Foundation, which is a studiously center-of-the-road health policy foundation. Here's what he said. Most of today's health cost strategies aim to reduce the volume of tests, procedures, and hospital days. Very few aim at the price of health services. Well said. We should have been said 40 years earlier. Now, HMO enrollment grew slowly in the 70s and the early 1980s. People just weren't excited about giving up choice in order to join this newfangled thing. But they did grow because they could keep their premiums a little bit below the premiums of Blue Cross and American Family Insurance and some of the other traditional insurers. How did they do that? Initially, they did it because they were enrolling healthier people. Healthier people were more inclined to give up choice in exchange for a slightly lower premium. And they had the luxury of not paying out-of-network bills. If you deliberately or mistakenly strayed outside their network, you didn't get your bill paid. That also allowed the HMOs to keep their premiums slightly below the traditional insurance companies. By the 80s, traditional insurance companies were getting worried about their loss of market share to the HMOs, and they began to adopt some of those managed care tools we talked about. And the HMOs responded with a new tactic. The new tactic was to demand enormous discounts from doctors and hospitals, 30, 40%. And if you go through a negotiation with a 1,000-pound gorilla HMO and you wind up leaving the table having given away that much money, you don't forget it. And what doctors and hospitals, particularly hospitals, did beginning in the late 80s was to start merging with one another so they could have countervailing power roughly commensurate with the power of the big HMOs the next time they went into negotiations with them. But as hospitals and doctors merged, the HMOs went, oh gosh, now we got to get bigger. And the genie was out of the bottle. And since the late 80s, we've seen constant consolidation throughout the entire healthcare industry. By the early 90s, there really were no traditional insurance companies left. They were all either HMOs or using some of the HMO tactics, particularly limited networks and utilization review. It wasn't until the late 1990s that some health policy researchers finally began to ask the question, is quantity really the issue? And they started publishing research saying no, price is the problem. And you had the slide up there. We're going to look a little more at this research in October, but let me just give you a taste of it. It's unequivocal. This is a quote from, I think it was 3 authors of this study in Health Affairs in 2003. One of the authors was from Johns Hopkins, another was, I think, Yuval Reinhardt from Princeton. And you see in the blue letters, the main conclusion. U.S. costs are high because we pay higher prices for goods and services, not because Americans get more health care. Now, why were our prices high? Well, the health policy community has not been eager to study this, but we've got sufficient amount of evidence that allows you to draw the reasonable conclusion. U.S. prices are high for 2 reasons. Skyrocketing administrative costs, both within the insurer sector, because it's expensive to monitor doctors and pay cap and mail with them and put networks together, and in the provider sector, and manic consolidation. Pretty much in any sector of the economy, as the number of suppliers shrinks, it gets easier for any and all of them to raise their prices. And both of those problems, rising administrative costs and incessant mergers, they were direct consequences of managed care, which were supposed to solve the cost problem. Let me show you just a couple of slides on this issue. Ann, can you go back to the administrative waste slide? Many people involved in the single payer movement have seen this. This is probably going to be an eye-opener for people who haven't studied health policy. What you see here, again, note where that curve turns up. That green mountain, that's administrative costs. It turns up around 1992, 1993. That's about the same time that mergers broke loose. Next slide, please. We've got 2 slides here. One of the few studies I've ever seen that give you a historical longitudinal view of the number and expense of mergers. This one is the value of the dollars spent by HMOs merging and acquiring. And again, notice that the uptick occurs right around 1992, 1993. Essentially what happened in those years is that Bill and Hillary Clinton endorsed HMOs as a solution in their bill, and Clinton announced it in the fall of 92 as a candidate. And here in Minnesota in 91, one of the first healthcare commissions in the legislature said, we think HMOs are the cat's meow. We're going to encourage enrollment in HMOs, and everybody saw the handwriting on the wall. HMOs are going to get bigger. We got to get bigger, and HMOs responded in kind. Next slide. And this is a slide showing you the value of a dollar spent amongst providers. It's not quite as definitive about 1991 and 1992, but you see roughly the same pattern, an explosive increase in mergers amongst providers in 1990, in the early 1990s, thanks to the growing faddishness of managed care and the increasing likelihood that state and federal legislators were going to endorse it. We'll talk more about this in the October webinar. By 1995, the widespread use of managed care tactics, particularly utilization review, had triggered an HMO backlash, as it was called. It's fun to look back on the symptoms of the HMO backlash now. I'll give you one example. A movie called As Good as It Gets was released in the late 1990s. It's about Helen Hunt and Jack Nicholson are the stars. And there's a scene in the kitchen where Helen Hunt is talking about her frustration with her HMO for denying services to her son, and she swears a blue streak. And audiences across the country applauded. The insurance industry claimed that the media and doctors were unfairly criticizing the insurance industry, but the research demonstrated that HMOs and managed care were in fact harming patients, and we'll go into more of that in October. By 2000, even advocates of managed care were suffering buyer's remorse. There was widespread recognition that it hadn't worked. I want to read to you probably the most definite and humorous expression of buyer's remorse that you'll ever find. It was stated by George Lundberg. He, for many years, was the editor of the Journal of the American Medical Association. And he was such a fan of HMOs and managed care that he even co-authored an article in 1996 in JAMA, begging doctors and Americans to have patience with managed care. Please don't do this backlash thing. Well, by 2001, he was fed up. And here's what he said in an interview with the Los Angeles Times. Managed care is basically over. People hate it. It's no longer controlling costs. Healthcare inflation is now back in double digits. So if it's not saving money, then why should we have it? But like an unembalmed corpse decomposing, dismantling managed care is going to be very messy and very smelly and take a while. In the end, managed care was not dismantled. Managed care advocates basically poured the same old wine into some new bottles in the early 2000s. I'm going to talk about that in just a minute. But before I leave the 1970 to 2000 era, I want to introduce you to the third camp, the high deductible skin in the game camp. When Bill Clinton introduced the Health Security Act of 1993, Republicans were again in the same position they were in 1970. Here we are, the Democrats proposing universal health insurance. They don't want the government that involved. They got to come up with something. And they came up with something called medical savings accounts. And by the early 2000s, they were calling them health savings accounts. I won't try to describe them now. Suffice it to say, the Republican rationale was almost identical to the rationale that managed care advocates had. Republicans were proposing very high deductible policies coupled with bank accounts into which you could deposit tax-free money if you intended to pull it out and spend it on medical care. You know where I'm going. The Republicans had the same diagnosis that the managed care advocates had. Their argument was that Americans overuse healthcare, and someone's got to make them stop it. Only the big difference between the high deductible camp and the managed care camp was the high deductible camp said, but overuse is not due to these greedy doctors who cave in routinely to fee-for-service incentive. It's dumb, overinsured patients. They compared medical care to food. It is such a brazenly illogical comparison. I'm going to read you one example of it, just so that you know I'm not making this up. Here's what Senator Phil Gramm of Texas wrote in the New England Journal of Medicine, beats me how it got past the editors, in an article explaining why America needs these high deductible things called medical savings accounts. Here's what he wrote. Imagine that we all carried grocery insurance. How would this affect our food purchasing habits? In my case, the answer is simple. Not only would I eat better, but so would my dog. In fact, if every American had grocery insurance, no grocery store in the country would sell dog food. Nothing less than steak would do. Very soon, the cost of grocery insurance would begin to climb. Yes, if gallbladder removal was like dog food and steak, yeah, the cost of gallbladder removal would skyrocket. But you could drop the price of gallbladders to zero, and there's not going to be a rush on gallbladder surgery. But that was their argument. We'll say more about the harm that high deductible policies are causing in the November webinar. Let me just close with a brief comment about the final period, 2000 to the present. And I'll talk more about it in the October presentation. The two most important developments in the first 2 decades of this millennium were the invention of new managed care schemes. The Accountable Care Organization, invented in 2006 and endorsed by the Affordable Care Act, became kind of a mini HMO. And it was everybody's hope that maybe if HMOs didn't work, ACOs would. They have not. But the enactment, the ACA's endorsement of ACOs further accelerated merger madness and added more to administrative costs. Second major feature of the first 2 decades of this millennium were that costs continued to rise relentlessly, again testifying to the impotence of these so-called cost containment reforms. And employers and individuals across the country responded the only way they could. They started buying very high deductible policies, not all of them with these savings accounts, by no means. Here's one statistic for you. Between 2007 and 2019, 15%, in 2007, 15% of the non-elderly were insured by a high deductible policy, $1,500 for an individual, $3,000 or so for a family. That number was at 51% in 2019. No wonder a third of us are saying, I can't afford healthcare. Many of those have insurance. So there you have it. The fundamental mess that legislators started trying to solve in 1970 has only gotten worse. Healthcare costs eat up 18% of our national income, and that in turn means it's contributing to the 9% uninsured. High deductible policies are spreading like crabgrass, and 33% of us every year fail to get the care we need because we can't afford healthcare. Why has cost containment failed? How did this happen? There are multiple factors, of course, leading to something, the outcome like this in a complex system. But the most fundamental reason is that the people who could have done something about it got the wrong diagnosis. They thought the problem was excessive quantity, and the problem was excessive price. You've gathered by now that 2 of those camps got it wrong, managed care and high deductibles. The one camp that got it right was the single payer movement. The single payer movement is saying it's price is the problem, and price is driven by administrative costs and consolidation, both of which got worse, thank you very much, to managed care. The evidence supports what I just told you, and it overwhelmingly rejects the managed care high deductible diagnosis and their solutions. I'm going to review that evidence in more detail in the next 2 seminars. And that's the end of my sermon.
Wonderful. Thank you so much, Kip. A lot of information in there, great information. Thank you for the history lesson. Multiple people have commented that this is, we understand where we're at now, but how we got here has been unclear until now. So thank you so much for mapping that out for us. Anyone who has a question for our presenter, please feel free. Once again, you can click on the Q&A button at the bottom of your screen. That will open up a text field. You can type in your question and click submit, and we will ask Kip. Our first question is from Claire. Claire asks, Claire states, this is interesting and informative. Where will the recording be available? Claire, this recording will be on Healthcare for All Minnesota and PNHP Minnesota's YouTube pages. A link will be emailed probably tomorrow to you. So look for that, and please feel free to share that link with family and friends. We are happy to answer any questions after the fact. So if anybody watches this presentation and then reaches out to our organizations, we're happy to answer or send those along to Kip. So thank you so much for your question, Claire. Our next question comes from Ron. Ron asks, Ron says, if someone reads Medicare summary notices, the person would probably conclude the Medicare reduces costs by lowering the reimbursement rates that can be charged for Medicare procedures. Can you say something about this?
That is one of the issues that we really do need to clarify. Single payer bills that have been introduced in the House, the old HR 676, and Pramila Jayapal's bill, current number I think is HR 1976, they do not specify that provider rates will be reduced to Medicare levels. I think that's wise not to specify that, because the savings we can achieve through administrative cost reductions are so immense. There's no reason to start out assuming that we must reduce provider incomes. But there are multiple other points to add to that. This is an excellent question. Number one, under single payer systems, hospitals are going to be paid, and nursing homes and possibly other types of providers are going to be paid budgets, the way fire departments are paid, the way libraries are paid. And in that context, rates makes no sense. The budgets will be negotiated between, in Minnesota's case, 142 hospitals and a Minnesota single payer, based upon need, not with any eye toward trying to extract huge discounts. So that's an important fact to remember about hospitals. There are some hospital executives who do think that if we go to a single payer, they're all of a sudden going to have to, all their patients are going to be paid Medicare rates. It's simply not accurate. They're going to be paid budgets based upon need. As for the doctors who are going to be paid fee for service, according to a uniform fee schedule, keep in mind that they're going to have lower overhead costs, substantially lower overhead costs. So even if in the end, either let's say the single payer bill were amended on its way through through Congress to lower rates for doctors, or that issue was left up to the Department of Health and Human Services at the national level or a Minnesota agency, and they decided to lower, keep in mind that that might actually be fair, because now, thanks to single payer, doctors are incurring far lower administrative costs. And the last thing to keep in mind is that doctors and hospitals are not going to be spending time and money chasing after patients who cannot pay bills, and they're not going to be expected to do any more charity care. That's been an expectation of hospitals and doctors for decades in this country. That expectation will evaporate under a single payer system. So I can sum that up again if you'd like to hear it, but I think that should be a fairly convincing answer to most people. Single payer is not proposing to reduce rates. You will see it, by the way, in some bills, and that annoys me. I think we should make it very clear that no one is proposing to reduce provider rates. If you look at a 2013 analysis of the old HR 676 by Gerald Friedman, he showed that single payer saves a lot of money, and he made no assumptions about reduced provider rates. hospitals will be paid budgets in which rates is irrelevant. Everybody's going to get lower administrative costs, and everybody's going to stop having to chase after unpaid bills and provide charity care.
Thank you, Kip. Great answer to that question. Thank you. Moving along, Juliana asks, is managed care where Reagan came in with DRG's diagnostic related to groupings?
Boy, that's no, the argument was not. No, the argument there was not overuse. The argument was that it made it easier for Medicare to ensure that, well, I take it back. I don't know what the motivation was for DRGs.
Do you want me to chime in a little bit?
Yes,
Kim?
if you know that, yeah, go ahead.
I was in the hospital, you know, doing bedside nursing when DRGs, this magic invention came in. I think our own Dave Durenberger was a large part of pushing that methodology. Their belief, and I think it kind of relates to capitation in a way, their belief was that if they created a system where a hospital got paid for one primary diagnosis, they would then be required to cover secondary and other diagnoses out of their own sort of pocket, that would encourage efficiencies. It was especially applied to hospitalization. It was completely irrational because somebody who's admitted to a hospital for something for, let's say, a hip replacement in there, that's their primary diagnosis, but they also have congestive heart failure and diabetes and hypertension. You're expected, the hospital was expected to account for all of those other diagnoses out of their current, revenue. I personally thought it was a failure in, it was misconceived right from the start. That's probably my best explanation for that. It still applies, but it has not really saved money because you still have to treat the patient for all the other things that they come in with, because a person is not a broken hip. The person is a system with a bunch of other diagnoses.
And you can see that the ideal solution would have been for Medicare to set budgets for hospitals.
Exactly.
Don't assign every blood draw and bedpan to a particular patient. But if you're Medicare, you're only insuring what, 15% of the population. It would make no sense to give Medicare authority to set budgets to hospitals that treat everybody. And so that was the imperfect solution in the 80s.
That's my contribution to that question. Thanks. Great. Thank you, Anne, and thank you, Kip. Thank you. Yeah. Our next question is from Kathy. Kathy speaks to current situation here. Is lowering the age of eligibility for Medicare the answer?
I think it's a very good incremental step in the right direction. I think some people insist on all or nothing. You've got to support, amongst the single payer movement, you've got to support single payer. And if you support something short of that, somehow you've harmed the movement. I just don't agree with that. If an incremental reform is moving in the correct direction, it is weakening the authority of the health insurance companies and expanding health insurance. We should support it. The original advocates of Medicare thought that Medicare would be a first step toward universal coverage. And my understanding is they thought the next step would be to cover everybody under age 25. And they thought that would be more politically feasible because they're so much healthier and would cost so much less. That, of course, didn't happen. But yes, I think gradually dropping the eligibility age is a great idea.
Wonderful. And then we're going to go to Dawn's question. She asked, can you please talk about traditional Medicare versus Medicare Advantage plans?
Well, as I mentioned in my presentation, Democrats and Republicans cooperated in 1972 in allowing these newfangled things, HMOs, to get their nose into the Medicare tent. From about 72 until 1997, they were paid 95% for each enrollee. They were paid 95% of the cost, the per capita cost of fee-for-service Medicare beneficiaries in their county. I'm going to keep this as simple as I can. The HMOs argued, we're so much more efficient. Our doctors are so much more efficient. Give us a shot. We will do this for 95% of what you're paying fee-for-service doctors to do. And they went by county because cost of living varies by county. And there were a lot of complaints about that because HMOs found out that they couldn't. They were not all that much more efficient. In 1997 and again in 2003, Congress instituted overpayments, much bigger overpayments to the HMOs than they were already getting. Let me just back up for a second. The HMO should have been paid something closer to 70% of the cost of insuring fee-for-service patients, because in the early days, they were attracting very healthy Medicare patients. By the 90s, as they were insuring more people, it was getting harder and harder to avoid the sick. And they complained about it. And Congress then increased the overpayments, particularly in 2003. And if you look at enrollment figures in 2003, enrollment in Medicare Advantage has skyrocketed since 2003. In 2004, Congress said, well, we don't want to pay any more based just on age and sex. Those were the only factors they were using to adjust payments to the HMO. So, you know, if an HMO got many older people, they get a slightly higher premium. They ordered the Centers for Medicare and Medicaid, Congress ordered the Centers for Medicare and Medicaid Services to implement a fancy algorithm that was supposed to predict the risk of every Medicare beneficiary with Medicare Advantage plans enrolled. And so if you enroll a patient with diabetes, well, your fee was raised by maybe 30 or 40%. And if that patient also had heart failure, whoa, now your premium is double what it otherwise would have been. You might have thought that that would work, but it didn't, because the Medicare Advantage plans figured out how to game it. They game it two ways. One, they know how to get rid of their sicker patients and send them back to fee-for-service Medicare. But more importantly, they know how to play this game. They look for more diagnoses. So they send nurses out to a patient's home and interview the patient to discover other symptoms. And even though a doctor hasn't diagnosed it, they come back and report it. And there's something called upcoding. They will diagnose, there are several degrees of sickness, for example, for a heart failure patient, and they will adopt the most severe indicator possible. Fee-for-service doctors don't have that incentive because they're not getting paid according to the risk, the health status of their patients. Are getting paid per service. And so this original idea that HMOs, and then in 97, Congress said insurance companies of all types can come into Medicare. This original idea that somehow, all right, we know we should be paying the HMOs less because they're getting healthier people, and we're going to adjust the payment based upon patient health status. It not only didn't work, it backfired. And really, since 1970, the early HMOs and now the Medicare Advantage plans are raking in hundreds of millions of dollars at the expense of the taxpayer. And what's truly upsetting about this is we're only a year or two away from the next great Medicare's going bankrupt scare. The latest prediction from the Medicare Board of Trustees is that the hospital Part A fund is going to be running short of money in 2026. That's what, a little more than 5 years from now. And long ago, we should have stopped the overpayments to Medicare Advantage. What's going to happen when Congress is asked to do something about the overpayments? Are they going to cut benefits? Are they going to raise Part B premiums? Or are they at long last going to stop the overpayments? It's a serious, serious issue. And if they don't stop the overpayments, I think eventually we'll see Medicare Advantage take over most of the entire Medicare program. They probably will avoid rural areas, but they will take over most of urban and suburban America if these overpayments aren't stopped.
Thank you, Kip. Oh, go ahead. Anne had something to add.
Jen, I'm going to invite you to go ahead and come back on if we can. Our convention is to be have the speaker spotlighted. I'm going to ask Jen to read the question from Sharon Schmidt, because I'll be the first to admit that that ERISA is not my strong suit. So here you go, Kip.
Okay.
All right, Sharon asks, how will ERISA plans be affected by one-payer system? Employers are allowed in the Minnesota Health Plan to pay their employees' healthcare costs. So my feeling is that in retirement, employers could continue to pay out money from accumulated retirement accounts.
Just so I could talk for 20 minutes about this, I'm going to try to keep it short. ERISA is the acronym for a law passed in 1974 by Congress, and it means the Employee Retirement Income Security Act. It was originally passed to protect pension funds, but at the last minute, Congress threw in a provision that also affects health insurance benefits paid for by employers. The goal was to make it easier for employers, large employers who had offices in multiple states, to deal with uniform laws governing health insurance benefits and pension benefits. But the effect of ERISA was to threaten, I don't know what word to use, to make it appear that if you attempt to do something at the state level, and it's not just single payer, any attempt to expand coverage, where you require employers to pay on a per employee basis, it appears that that will violate ERISA. But I say appears because it just is not clear. ERISA is a very vague law. Reading Supreme Court decisions on it is like reading some really strange esoteric religious document. It's very hard to say where they would come down on that. Here's what I'm fairly sure of. And note we're talking only about the state single payer bills. The feds can do whatever they want. So Pramila Jayapal's bill, ERISA in the U.S. House of Representatives, ERISA is irrelevant to her and to Congress. ERISA is only a problem at the state level. I am fairly confident, but I can only say fairly, that if a state does not attempt to raise money from employers on a per employee basis, but rather just does it on a payroll basis, X% of your annual profit, or the way workers' comp is financed. As long as it's a general tax, it's not linked to particular employees, then it should pass the ERISA test. There is a bill that has been drafted by a California legislator, Ro Khanna, that would specifically defang ERISA and would make it possible for states to pass universal coverage, whether it's multiple payer or single payer, and tax employers if that's what they wanted to do, and not run afoul of ERISA.
Very interesting.
Let me just finish the question. So she was saying, the question was, since they have retirement, money set aside for retirement, wouldn't they be able to afford it? They may well. That is just irrelevant to the legality, to the legal question. Whether they can afford it or not, I'm fairly confident that if a state were to formulate the tax so that it is based upon the number of employees that an employer has, the courts will say it violates ERISA. Now, they may not throw out the whole law. You just may be back to the drawing board trying to figure out how to pay for your single payer bill.
Great, thank you. Our next question is from Liz. Liz says, might single payer encourage a two-tier health system? I ask because an Irish citizen described their system as the public standard care, but if you were wealthy, you could go to private hospitals for better care. Could we see a potential for a two-tier system with a public option, or keep the private insurance you have? Great question, Liz. Thank you.
Well, you wouldn't see it in the Minnesota Health Plan, which is the insurance that Minnesota PNHP and HCAM have been supporting for decades. You wouldn't see it in the old HR 676 or Pramila Jayapal's bill. The only way we get a two-tier system is if, in the course of the bill moving through legislative committees, someone successfully amended the bill to say, if you don't want to buy from this single payer, you can buy from an insurance company, and we will help subsidize the premium payment. I suspect that if there were no subsidy for the premium payment, you might get a few rich people buying out, but I wouldn't think at $20,000 for family, there'd be a whole lot of people wanting to bail. The critical question would be, would the amendment offer subsidies to people who say, I don't want to buy from the Minnesota Health Plan. I'd really prefer Blue Cross, and I'm going to ask to be subsidized when I do that. If that were to happen, boy, I don't even know. Well, there are other problems besides a two-tiered system. Mainly, it gets harder to claim any big administrative savings if people can just jump out and use a voucher to buy health insurance from the existing health insurance company. You wouldn't even have a single payer system if an amendment like that were to succeed.
And let me comment that it's our job as advocates to make sure that doesn't happen.
Yep.
The bills, both Minnesota Health Plan and HR 1976, specifically prohibit selling insurance for any benefits covered under the bill, the Medicare for All bill, or the Minnesota Health Plan, which of course is why you will hear opponents say, well, did you know that prohibits commercial insurance? Yes, that's the whole idea. So be aware that will be used as a scare tactic, and it's our job as advocates to make sure that we do not have a two-tiered system, and that equity is at the top of our list.
And you can imagine the rampant confusion that would exist if you, there'd be fraud artists calling people at home every day saying, this is the bill, this is an insurance that the legislature just passed. Yeah, you don't want that.
Great. And it looks like we do have time for one more quick question. And that is from Steve. Steve asks Kip to please comment on fee for service versus salary for doctors.
Fee for service, salary, and capitation really are the three major ways of paying doctors and other professionals. And they each have their own incentive, and none is perfect. The argument for salary basically is that you removed all incentives to overuse and underuse. And I have no quarrel with salary. I understand some people think that it encourages doctors to go home early. They're getting a salary, doesn't matter how hard they work. I tend not to believe that. I think people that survived med school didn't go into medicine to go home early. But the trouble with salary as a mechanism of paying 800,000 American doctors is you would have to be talking about true socialism in order to put all those doctors on salary. And that just is a path we chose, the single payer movement a long time ago decided not to follow, to make doctors and nurses employees of the federal government. And so I think we're left basically with two choices, fee-for-service versus capitation. I will always prefer fee-for-service for reasons I've already laid out. Anytime you capitate, you have to risk adjust accurately so that you're not overpaying for the healthy and underpaying for the sick. It cannot be done accurately. And it means you're creating a reverse Robin Hood effect. You're shifting money from docs and hospitals who treat a disproportionate share of the sick to those who treat a disproportionate share of the healthy. The reason I really like fee-for-service, despite its problems, is if I have a problem with a doctor or a hospital, I don't need the US Army and the Marines and the Air Force to come in and overturn the decision. But if you have an HMO or an insurance company telling you, no, you can't have this operation of this drug, you're in for the fight of your life and you will often lose it. Fee-for-service guarantees autonomy both for physicians, much more autonomy for physicians and patients than capitation does.
So I encourage on that subject, and you will get lots of questions both from providers and from advocates. I encourage people to go to that bill, HR 1976. It's actually not, it's actually pretty interesting to read. It's about 140 pages, but double spaced, and there is information in about how providers will be paid. And it's not just doctors, it's psychologists and physical therapists and other people who are designated as providers. And there's some flexibility about how these providers will be compensated. So thank you so much, Kip. We look forward to the next two. I'm gonna go ahead and, we'll just, you want to comment on the last three slides before I go into announcements?
No, I'll comment on them. We'll get into that in the October.
In the next three set. Okay, so yeah. To be continued.
Yes.
Okay, let me just end with some announcements. I will call your attention to the 3 sessions that our social media team for Healthcare for All Minnesota and Physicians for a National Health Program Minnesota prepared and provided over August and September. They were during the lunch hour, so you might have been there, you might have missed them, but they are available on our YouTube channel, Healthcare for All Minnesota. We ask, since we're in a virtual, world right now for a while, that you go in and like, follow, share, and even post on or suggest information that we could put up on our social media platforms. And we need more activity, and that's us as advocates to go in and interact with these sites. So I put the addresses, and you'll get these slides after this presentation. I put the addresses for all 3 of these platforms. Continue to call, write, or respond to action alerts. We just sent out an action alert, and I may just show that at the very end. We've got, using our email list, we can contact everyone on our list and ask you to send in a message to, in particular, this time it's Senator Amy Klobuchar. We really need her to support all of the provisions of the Medicare expansion. If you've attended any of our sessions, you know that there is a proposal as part of the American Families Plan, which is being debated this month in the Congress, that would lower the eligibility age for Medicare to 60, would expand benefits to include vision, hearing, and dental care, would cap out-of-pocket costs, and would require or allow the government to negotiate drug prices. Amy Klobuchar is on the record as being all in for negotiating drug prices, but the rest of it, not so much. So we need her to hear from us. So please respond to that call to action. Other events are on our website, which is actually HTTPS, but hca-mn.org. And then please join us for the 2nd and 3rd of the series, which will be October 14th and November 11th. Also, I'm just going to let you know to look for a newsletter, which our first edition of a Healthcare for All Minnesota newsletter we will be sending out in the very beginning of October. Jen Crawford for PNHP Minnesota has been doing a fabulous newsletter. Neither of our organizations are dues-based. You can sign up to be on the mailing list for both of our organizations, and we would love to have you do that. So please go. If you got this invitation today from our mailing list, you're already signed up. If you got it from a friend or another activist, then please go to that website, hca-mn.org, and give us your contact information so that you can hear from us. And then be sure that we have complete contact information, because that lets us target our calls to action to you based on your congressional district or your legislative district. And got some my contact information here, and then Kip's contact information. He's available. Any comments, Kip, on that?
I'd be glad to answer any questions people have.
Via email.
Yep.
Okay. And okay, Jen.
So thank you everyone for attending today. This is our first in a 3-part series again. So we look forward to seeing all of you back here in October on the 14th for part 2 with Kip Sullivan. You will be routed to a survey after you leave our presentation today. We hope that you'll take 2 minutes and fill that out. We value your feedback. It helps us put together future presentations and make sure that they are the content that you are looking for and that you feel the most applicable for your lives right now. So we thank you so much. Kip, thank you so much for joining us again this evening, and we look forward to seeing everyone back here in October. Thanks so much. Good night, everybody.
While we're still on, Jen, I was going to glance really quickly at the chat just to see if there's anything we missed.
I think we got them all.
Wanted to include. Okay, most of this is kind of conversation back and forth. Okay.
Great. Well, thank you, everyone, and we'll see you back here in October.
Okay.
Bye.